right, good afternoon, everyone. Welcome to the first of a 6-webinar series focusing on treating patients with disabilities. Today's webinar focuses on the current state and barriers in special care dentistry. My name is Adam, Content Marketing Specialist with Schein, and I'll be your moderator. I would like to thank all of you for attending. If at any point during the presentation you have questions, please type them into the Q&A section of your control panel and we will answer them live at the end of the webinar. Directly following today's webinar, we're asking that you complete a quick survey to let us know what you thought of the presentation. If you elected to receive CE credit for this webinar, it is required that you complete the survey in order to get your CE certificate. It's also required that you attend this webinar for the entire duration. Your CE certificate will then be emailed to the email address provided during registration and your account will be billed. Schein is only able to offer CE credits to doctors licensed and practicing in the United States. If you have questions about CE for this webinar, please email us at webinars@henryschein.com. I am very excited to welcome our speaker for the series, Dr. Maureen Perry. Dr. Perry is the Professor of Special Care Dentistry and the Director of the Center of Advanced Oral Health at the Arizona School of Dentistry. In addition, Dr. Perry is a Fellow of the Academy of Dentistry for Persons with Disabilities and as a diplomat of the American Board of Special Care Dentistry. Thank you for presenting on this topic, Dr. Perry. The floor is yours.
Thanks so much, Adam. Well, welcome everybody. And I wish I was in person, but happy to see you all virtually. It's our disclaimer, so you guys know about your CE. And here's my disclosure. I am being compensated by Schein, and the views expressed here are solely mine, and Schein does not guarantee the accuracy or reliability of the information. However, everything is referenced. So here's where I work. It's called the Center for Advanced Oral Health, and it's in Mesa, Arizona. And it comprises the entire second floor of that building, which is over 22,000 square feet. And it has the orthodontic clinic and the advanced care clinic. The Dr. Rick Workman Advanced Care Clinic is a special place, and this is the kinds of patients we see. So when we say special care, we mean the entirety of special care. So people with cancer and cardiac disease, to people with transplants, Alzheimer's, and people with intellectual and developmental disabilities, which we're going to talk about today. So here's our learning objectives. We're going to talk about the historical events that led to the current social context of disability in America. We're going to describe the barriers to care for this population, and we're going to talk a little bit about dental education and what's going on in this area. So, Special Care Dentistry Association defines special care dentistry as that branch of dentistry that provides oral care services for people with physical, medical, developmental, or cognitive conditions which limit their ability to receive routine dental care. So here's my disclaimer. I am a former president of the Special Care Dentistry Association, and I've been a member for over 25 years. Great organization, 501c3, good group of people who are doing this either full-time or part-time, and just getting lots of information and education. And it's basically the group of people who just do special care all the time. So check us out online. What is a developmental disability? Well, that is an impairment in physical or mental abilities that happen before age 22 and persist indefinitely and result in functional limitations and major life activities. And that's the federal definition. And the reason that it goes to age 22 is because Medicaid, children are covered under Medicaid, kids with disabilities until age 21. So this is the federal definition of developmental disability. Again, has to happen before you reach adulthood. What is an intellectual disability? Well, that's a disability characterized by limitations in intellectual functioning and adaptive behavior. And we talk about practical and everyday skills. And you can see the American Association for Intellectual and Developmental Disabilities says it's before the age of 18. So you see a slight difference there in the definition. And again, developmental disability is sort of the overall umbrella category. And then we talk about intellectual disability as its own entity. Why do you need to know about developmental disabilities? Well, about 13% of kids in the United States have a developmental disability, from anything from mild like speech and language impairments to things like intellectual disability, which we'll say ID, CP, or autism. So that's 1 in 6 children. So when I talk to my students, I say, if you think you can make a living and not treat, 1 in 6 people, that good luck paying off your massive student loans, right? So a lot of people have disabilities. So when we talk about developmental disabilities, this is for the rest of the series, we'll talk about this in a bigger context, but these are the 4 big developmental disabilities: intellectual disability, cerebral palsy, epilepsy, and autism. And developmental disability is the umbrella category for all of these, very specialized finite disabilities. So let's take a look at what some folks who have a disability have to say.
People with Down syndrome have special needs. Special needs? Really? It would be special if people with Down syndrome needed to eat dinosaur eggs. That would be special.
1 dinosaur egg. Enjoy.
Man, I think you were totally right about Lindsay.
If we need to wear a giant suit of armor, that would be special.
I got a condo in Manhattan. Baby girl, what's happening? So gonna get to clapping. Go pop a phone.
It would be special if we need to be massaged by a cat. If we needed to be woken up by a celebrity.
Wakey, wakey, eggs and bakey. Where are you? You may know me from Scrubs or Office Space. A few darker flicks, The Rock, Platoon, Wall Street. Funny story, I played Ben.
Get out.
My bad.
That would be special. But what we really need is education, jobs, and opportunities, friends, and some love, just like everybody else. Are these needs special?
So I really like that video because it really sets the stage for kind of what we think, special healthcare needs. You might see that in the literature. You'll see like people with SHCN. I like to use the term special care or advanced care because exactly for the same reason, because everyone has a special need. But for people who do have a special need, and this is a 2000 study published in 2000, dental care is the most prevalent unmet need amongst healthcare needs, okay? So dental care is the greatest public health problem facing U.S. children. The issue is particularly concerning for kids with special healthcare needs who have a higher prevalence of unmet health needs. So you see in 2000, we had the issue. In 2015, we don't see really things getting much better. I can tell you that this statistic is still true. So what kind of disparities do we see in people who have any kind of need special care? I would say, well, periodontitis, it's 2 times higher than in the general population, and edentulosum is at least 1.5 times higher. So we see big oral health disparities in this group. There's much higher risk of oral disease. We see compromised oral hygiene, and that's sometimes a consequence of a person's impairment, or it might be an oral manifestation of their particular condition. And as we go through in this series, the different particular conditions, we'll address those. And here you see somebody obviously with rampant caries, and sometimes we see xerostomia from the drugs that patients are on. And also with children in particular, we see lots and lots of sugar in medications. Almost all the liquid medications are filled with sugar. So we see this as another big problem. Unmet need for medical care. Patients will have delayed medical care versus people who are not disabled, and they may not get the medical care they need versus people who are not disabled. What kind of barriers do they have? Well, they might have trouble making a timely appointment and accessing transportation. You know, you and I, if we're going to go to the dentist or we're going to go to see our physician, we just get in our car and we go, right? We just hop in the car and go to our appointment. But what if you had to call for Accessoride, or if you had to get a taxi? What if you need an ambulance or an ambulette? So you have to do that, right? And you have to coordinate all of that care. And it might take you all day to get an appointment that's going to take a half an hour, because you have to wait for the ambulette. You have to go down to, maybe if you live in an apartment, you have to get downstairs, you have to wait for the ambulette, and you have to go where you're going. The ambulette's going to come back at a certain time. So if your appointment's over soon, that you just have to go and you have to wait. It's not like you know, so for some folks, that's really a barrier. And, you know, I think for some people that does explain why they don't get care, or why they delay care, because it's kind of a whole big rigmarole for patients, and they just can't deal with it. Some other issues and oral health care disparities, and some of you might have seen this, was on the cover of JADA in 2015. For people with disabilities, they have trouble getting exams. There's delays in obtaining needed oral health care, and they really have an issue with the ability to obtain the needed care. Now, if you take that into consideration, if you have a disability and you have a membership in an underserved racial or ethnic group, then you might have a greater magnitude of disparity in all three areas. This is a huge problem. We see it in inner cities. We certainly see it where I am in Arizona with our American Indian population. You may see it amongst Alaskan Natives. So people who are disabled and also a member of an underserved racial or ethnic group really have a double whammy of a challenge. You guys may remember the Americans with Disabilities Act, and that prohibits discrimination on the basis of disability. Many of my students weren't born when this act actually came to be in 1991, and it prohibits discrimination on employment and services, public accommodations, and of course, that includes dental offices, as we all know. And one of the things you might not know is that it does say that services to individuals with disabilities must be offered in the most integrated setting appropriate to the needs of the individual. So you can't segregate people with disabilities. You can't provide a different waiting room. You can't, you need to integrate them into your practice. And that is a very important aspect of this law. So something to think about is that, you know, equality does not always mean justice, right? So people with disabilities may need other accommodations so that they can get the care that they need, right? So what kind of huge barriers do folks face? Well, they face huge financial barriers, right? Because most people with are individuals with intellectual and developmental disabilities are covered by Medicaid, right? Whatever you're going to call it in your state. And because Medicaid is done by states, right? State to state is different. So for kids, there's their early screening, EPS, Early Prevention, Screening, Treatment, and Diagnosis Act. So all children with disabilities are covered under Medicaid till age 21. Adult Medicaid is state by state. So if your state may cover dentistry for adults under Medicaid, and they may not. It depends on each state. Some states like New York have a very generous program. Then there are states like Arizona where we have $1,000 limit on it. And for 8 years, we didn't have any coverage at all. Some states don't have coverage for people if they're an adult, even if they have a developmental disability. There's other issues like behavioral issues. So sometimes people will say, well, what if the person is acting up in my waiting room? And what if they are, misbehaving or doing something strange and everyone's looking at them? Well, I always say, isn't that a great opportunity to talk to your children or for you yourself to realize that there's all kinds of people in this world, and we have to have empathy for everyone, right? You haven't walked in their shoes. You have to think about that. So what about that poor parent that's sitting there while the child with autism is having an absolute meltdown? And it might not be in a waiting room. What if it's in the store? And what if you're in Target? Or, think about that. It's really difficult for parents and for caregivers. So have some empathy with the behavioral aspects of it. And we're going to talk a lot more about that as we move further in the series. Here's the big one for today that we're going to talk about: the lack of dentists who have received education and or any kind of clinical training in providing care for people with intellectual and developmental disabilities. So who are we actually talking about? Well, you know what? Kids, particularly, and there's good studies on this, that kids who need special care overwhelmingly are more likely to come from families with incomes below the poverty level, from less educated households, and from single parent families. So if you look at that, boy, that's a lot of financial barriers. That's a lot of social barriers. You may have some dental IQ barriers there. I mean, we're just piling on the barriers for kids with IDDD. What about the parenting stress, as we talked about? So, you sometimes see people, trying to struggle with their kid, trying to get them in the car or trying to get them, sitting down in a restaurant when we all used to go to restaurants. So things like that, very high parenting stress. Parents are at a risk for major psychological and social disturbances, and they can be at huge financial strain for dealing with their kid who's got a disability. It also really upsets the balance of the family when you have other children. And, the kid with the disability is the one who always gets the attention. This can create other strains in the family. And we often see kids without disabilities either doing one of two things: either being the totally model child and helping their brother or sister, or really, really acting out and creating even more strain in the family. So really try and be empathetic when you're dealing with families, because they've got a huge amount of stress. And we're thinking about, we're just thinking about our dentistry. What about when this child has to get a vaccine, or when they have to have a haircut, or even something simple like getting their nails cut? How is that going for a parent? So in 2005, the Surgeon General's call to action talked about working with people with disabilities and the overall health and wellness. And this is a quote directly from that report. And it said, "The disparity may arise in part from a lack of providers trained in special care dentistry." Well, that was an understatement for sure. Let's look at dental education in 1999. So in 1999, 53% of dental schools reported fewer than 5 hours of didactic training in special care dentistry, and the clinical instruction was somewhere between 0 and 5% of the pre-doctoral students' time. So here is a complete disclaimer yet again. Romer M is actually me. That is a former name of mine. So this is actually my study. The nice thing about changing your name when you're mid-career is you can cite yourself with impunity. So here I am citing myself. But this was a study that I did with my good friend Nancy Dougherty and one of our fellows. And this is one of the first studies on this. We move ahead to 2007, and what we see is that 40% of institutions that responded had special care clinics, as compared to 38%. So 8 years later, not much had changed. But hold on, because things are going to change, because CODA has decided that they should change. So let's talk about that. So sorry about that. So the value of education in special care dentistry as a means of reducing inequalities in oral health. And this article came out in 2012. Now, in the meantime, CODA, the Commission on Dental Accreditation, part of the ADA, had decided that we should have some sort of formal education for students in dental school, working with people with what they called with special needs. And that included vulnerable elderly, psychiatric patients, patients with medically complex conditions, intellectual and developmental disabilities, physical disabilities. And they said that you had to be able to assess people. And all that means is you could look at a video and you could pass that standard. You could just show a video to students and that would be fine. So that went on for several years, actually, until the current standard, which we're going to talk about in a minute. So what was going on worldwide? Well, worldwide, more than 18% of the population has a moderate to severe functional problem related to disability, and they'll need special care at some point in their life. 90% of people requiring special care dentistry should get it through primary care, right? And primary care is only possible through the education and training of dentists. So we go from seeing this as a United States sort of problem, and you look at the bigger world view and you see that, wow, this is a problem, you know, everywhere. People are having the same sort of issues in accessing education and primary care. So there's kind of a worldwide movement, and the Education and Special Care Dentistry, the IADH, which is the International Association for Disability and Oral Health, another organization that you can join. They have a fantastic online presence, lots of resources. And they think that the development of recognized academic and clinical discipline, so making special care an actual its own discipline, and we should have international curricula guidelines. I'm happy to say that those guidelines, of which I was a part of writing, have actually been published and are available, both for pre-doctoral special care dentistry and for postdoctoral education. In many countries, special care is already a specialty, so places like Brazil and the United Kingdom, as well as Australia. So it is an actual dental specialty and people are getting trained in it. So why would people, you know, do special care? Like, what influences people to want to do it? What are those outliers? What are the people like me doing? The key determinant is clinical experience, okay? And there's two things that influence people's willingness to treat: their clinical skill set, how prepared they feel in special care dentistry, and their overall comfort in dealing with people with intellectual and developmental disabilities, as well as general special care dentistry. So, you know, dentistry is extremely experiential. I don't think any of us are going to go out there and start taking out third molars if we never did it, right? You do stuff that you learned in school, you do stuff you learned in your residency, you do stuff that you've learned in continuing ed. You have to physically do it. We don't like to just read a book and then, okay, we're going to go do this. We really want to do it. So you have to have that skill set, and the skill set gives you the confidence to move forward. But you have to have that initial interest in it, right, to understand what you need to do. Here's a study, the most recent study I found, which is from 2020 at the University of Pittsburgh, and talking about the same thing, that the perception of preparedness during dental school training time is really important, and that the more experience people had, the more they felt prepared to treat. However, in looking at the actual practice patterns, the treatment rates really didn't differ. People didn't actually do it. Now, granted, this is there's some issues with the study, and not that it's not a well thought out study, but you know, it's hard to get students to respond. So it was hard to get graduates to respond. So you tend to get low response rate for these sort of studies. So whether people were actually doing it or not doing it, it's hard to say. We know that some people do. But we do know that from the literature that the more experience people have, the more likely they are going to be prepared to treat. Now, starting in 2000, let's see, I think it's going to, well, it's going to be now in 2020, the CODA standard is now going to be that people have to manage a person who needs special care dentistry. Okay, so you have to manage them. And what manage means in CODA means recognize and refer. So we went from assessing, which is just looking at it, you can watch a video, you can look at another person doing it, and you can say, yep, that's a person with special needs. And that's not quite enough to get people to do it. So now we're on to manage. And in manage, we say, well, you know what? I recognize that you have a special need, and I have assessed you, and I have decided to refer you. So you actually have to meet the person. So we're moving along, and I'm very hopeful that one day it will say that all dental students have to learn to treat a person with special needs. Now, in the postdoctoral standards, it does say you have to treat. So in for AEGD and GPR, it says you have to treat people with special needs, and it's the same definition, sort of that overarching definition of people with medical complexities, intellectual developmental disabilities, physical disabilities, and the vulnerable elderly are all in that one definition. So if you graduated before 2006 from dental school, it is very likely that you did not have any or maybe very limited exposure to people with any kind of special healthcare need, or specifically with people with intellectual and developmental disabilities. So it's not like you missed it. You weren't sleeping. You weren't out getting a cup of coffee and left the building or something. Yeah, you really just didn't have it in the curriculums. So how are we going to fix this? And there's Margaret Mead, and she was a very smart lady, and this is a famous quote of hers. And so, yeah, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So I'm happy to invite all of my thoughtful, committed citizens who are on the webinar with me to move forward, and let's start fixing that. So besides not learning anything in dental school about this before 2006, and probably from 2006 to 2020, learning very limited. In some places, I won't say a blanket statement. There are lots of places that do a great job teaching special care. Certainly at AT Still, at ASDO, we've been doing it for a long time, but understanding that dental curriculum is it's just jam-packed with content. And so carving out time for something that is not a standard and is not required is pretty difficult for most dental schools. Because we were a new school, we were able to really integrate it pretty easily, but for more traditional schools, it can be quite a challenge, which is why it's so awesome that Pittsburgh was able to do it, because, being an old traditional school, they were totally able to get that into their curriculum, and they're doing a great job. And there are many schools that are doing a good job, but there are also many schools that now are trying to catch up with those who are moving things forward, and that's a good thing too. So what else affected folks with IDDD? Well, they had an increased life expectancy. And right there is a gentleman, his name is Mr. Wildgust, and he is the oldest person alive with Down syndrome in the UK, and he's 77. I have two patients who are in their late 60s with intellectual and developmental disabilities, both with Down syndrome. So you can see people can live a really long time. And then when they live a really long time, they start to have the same problems that all people that live a long time have. They start to get hypertension, and they start to get diabetes, and then they may get Alzheimer's and all sorts of other problems with aging. But there was also a major issue, and that was deinstitutionalization. So until the mid-20th century, most people with developmental disabilities lived with their family, right? So if you had a person with a disability, they just stayed within the family unit or the extended family, and they were raised with everyone else. But after World War II, there was this sort of paternalistic idea that we should have sort of training for people, or developmental centers, that people shouldn't just be stuck at home, that they should have something to do, a place to go, maybe a place to learn things and develop skills. And so it started out as a really great idea. I think we all know that this does not end well. And here is a picture from the New York Times from 1960, and it says, Dr. Saul Krugman believes he is serving mankind by producing hepatitis in mentally retarded children in New York State institutions. So, there's something that's not so great about our history here in America. We've been learning a lot about the history of America, and this is just one more thing. So again, experimenting on people who really couldn't give consent in any meaningful way, really awful. In 1963, the deinstitutionalization and community services for people with disabilities moves forward as the then President Kennedy calls on Congress for legislation to reduce the number of people in custodial care in institutions. And many of you may know that the reason that President Kennedy was so zealous about this is that he had a sister, Rosemary, who had a developmental disability. And Rosemary, was very close and near and dear to him. And as much legislation gets done because it was a family member, right? So he really wanted to make sure that people with developmental disabilities had more opportunities in the United States. And we're going to see that go on with the Kennedys as a theme. So in 1966, two really exciting things happened in Staten Island, New York. Number one, I'm born. Maybe not so exciting for you, but exciting for my family. And Robert Kennedy visited the mental institution known as the Willowbrook State School, and he declares it not even fit for animals to live in. And so let's see what what Robert Kennedy has to say about that.
Well, I visited the state institutions for the mentally retarded, and I think particularly at Willowbrook that we have a situation that borders on a snake pit, and that the children live in filth, that many of our fellow citizens are suffering tremendously because lack of attention, lack of imagination, lack of adequate manpower.
And so we see that the Kennedys are taking a great interest in this, and Bobby Kennedy is interested in it, and so is his sister, Eunice Shriver Kennedy, who is the closest in age to Rosemary Kennedy and is actually the founder of the Special Olympics. She was a great athlete, Eunice, and she loved to take her sister swimming, and she would take her to anything athletic she was doing. She wanted her sister to participate in, and eventually she founds the Special Olympics. So here's a fellow you might recognize. Many of my students don't recognize him because they're so young. And then when I show them this picture, they say, oh, it's Geraldo Rivera. So they recognize Geraldo today. He has done tremendous work with people with developmental disabilities, and he still has a foundation. It's located in Long Island and works with kids with autism. So when he was on Celebrity Apprentice, he actually won Celebrity Apprentice, and he gave all of the money he was paying for his foundation that works with children with autism. So 1972, he infiltrates the Willowbrook State School. He is using a stolen key from a fired doctor, and he documents the horrific conditions there. And there's a government inquiry, and he wins the Peabody Award for this. So let's take a look at what was happening then.
It's been more than 6 years since Robert Kennedy walked out of one of the wards here at Willowbrook and told newsmen of the horror he'd seen inside. He pleaded then for an overhaul of a system that allowed retarded children to live in a snake pit. But that was way back in 1965, and somehow we'd all forgotten. I first heard of this big place with the pretty sounding name because of a call I received from a member of the Willowbrook staff, a Dr. Michael Wilkins. The doctor told me he'd just been fired because he'd been urging parents with children in one of the buildings, building number 6, to organize so they could more effectively demand improved conditions for their children. The doctor invited me to see the conditions he was talking about, so unannounced and unexpected by the school administration, we toured building number 6. The doctor had warned me that it would be bad. It was horrible. There was one attendant for perhaps 50 severely and profoundly retarded children.
The ones that we saw were the most severely and profoundly retarded. There are thousands there like that, not going to school, sitting on the ward all day, not being talked to by anyone, only 1 or 2 or 3 people to take care of 70 people on the ward, sharing the same toilet, contracting the same diseases.
Can the children be trained?
Yes, every child can be trained. You know, these kids, there's no effort. We don't know what these kids are capable of doing.
So pretty shocking. So, you know, here's this idea that we're going to train people and we're going to give them a better life. And as you can see, that is not at all how things turned out. Things turned out pretty horribly at Willowbrook. These are some pictures that are from Life magazine from right around that time. Here it was on the cover of Life, and you can see just the horrific conditions that were going on at that time. I apologize for the quality of the video, but please listen to the audio here as we find out that's what's going on in the East Coast, and here's what's going on in California around the same time. So this is, again, early 1970s, so right after Willowbrook. So this is around 1972, 1973.
And I think your priorities are mixed up in New York in terms of serving the retarded. Your top investment is in institutions. Our top investment is in the Department of Education and in providing a program for the child while he's at home in terms of daycare. For example, these kids can go to school at age 3 years. So they start at very young, and that helps a great deal for parents. And when parents are actively encouraged to keep their child at home, they do so because they know they can have the help of regional centers or public schools or the health department in terms of services, etc.
What we need is a new approach. We have to change the way we care for our mentally retarded. We ask for change, we demand change. What you've seen here just doesn't have to be this way.
I think all of us are at fault. And I think it's just it's long overdue that something be done about it.
So again, pretty shocking. In California, there still are regional centers. So in California, lots of regional centers, and the regional centers there support people with IDDD and their families. They have day programs. They and they also have some clinics and other things. And so that was going along pretty well. And so many other states have adopted that. One of the things that's interesting and of note is that you'll notice that when we showed that institutionalization in the developmental centers, that there were doctors there. There were also dentists there. I myself, actually, when I was as I say, a little baby dentist, I was doing a fellowship in special care dentistry after my residency program. And when I did my fellowship, I actually had to go out to Willowbrook, which was no longer, there weren't people really living there. There were group homes where the doctors had lived in these large colonial mansions, and the administrators had lived. They had moved folks into there as really nice residential group homes. And so there were people living on the campus, but they still had a medical and dental clinic there. And so I was assigned one day to go over to the dental clinic. And when I got there, much to my surprise, now this is in 1992, 1993, so you're talking like 20 years after the videos we saw, there was actually a rheostat you pushed sideways with your foot, and there was a belt-driven handpiece. And I, having, recently graduated from dental school, I took one look at the belt-driven handpiece and decided everyone was getting a Cavitron and a cleaning. I was not going to be using that thing. So they did, one of the issues, of course, is that we had places when people were institutionalized, they could just go to the physician or the dentist. It was right on campus. It was not a problem. But as we deinstitutionalized people, they moved to the community in a group home. And where was that doctor? Where was that dentist who was going to be treating people who needed such high levels of special care? And no one was trained to do it, right? It wasn't being taught in dental schools, and these folks weren't in our community, so no one needed to do it. There were a few people who needed to know how to do it, and they worked in places like Willowbrook. But now all of a sudden people were living amongst everyone else. And where were the doctors? Where were the dentists, right? They weren't trained. So in 1975, there's the Willowbrook Decree, and initiates the movement to deinstitutionalize the whole state. Now, because New York is such a large state, there were 30,000 people living in these kinds of institutions. So imagine 30,000 new dental patients just spilling out into the community, and there are no dentists who are prepared to treat them, right? At all, right? There just isn't, because maybe there were 5 or 6 in the institutions, and now we have all these folks out living with us. By July 2000, 12 of the original centers were closed, and by 2017, all of them were closed except for people who needed intensive treatment needs. And those were like residential places. They're more like nursing homes. So they're for people who needed 24-hour a day residential care. And they're operated by the Office for People with Developmental Disabilities in the New York State Education Department. So you can see that, we really didn't do a great job of preparing our physicians or our dentists, right, to be seeing all these folks. So, you can let go of the guilt as a provider that you didn't maybe have this skill set because you weren't taught it. I don't think we can let go of the guilt as a society for the things that went on, but we can learn from it, and we can certainly move forward, and we can make life better for people with intellectual and developmental disabilities. So the thing that's important is that we have to remember that US has a really complex history related to the way we treated people with disabilities. And most of our folks, they're living in the community. We see them every day. When I was a child, I occasionally might see somebody with a disability. And I remember being at a little amusement park and seeing a kid who clearly had a disability, and I couldn't understand. I said to my mom, why does she look that way? I still remember it because my mom took the opportunity to tell me about how there were people with different kinds of disabilities. And I had a cousin who had Down syndrome, and she said, well, like your cousin Anthony, like there are all different kinds of people in the world, and some people look different because of their disability. And, now it's not, I mean, I think it would be very unusual if you had a 5 or 6 year old who hadn't seen a person with a disability, right? People are living in the community and integrated as they should be. The other thing is people with developmental disabilities have unique barriers accessing dental care. So imagine if you don't feel like going to the dentist, what do? You call up the dentist and you're like, who's probably your friend, and you probably have to lie, right? So you say things like, oh, my car's not working, or I have an emergency at work, or I got a late patient and I can't come over. So we say something that we think is socially acceptable, and then we don't go to the dentist and we reschedule it, right? But imagine you live in a group home and you don't feel like going to the dentist. Well, that doesn't stop the people who run the group home from putting you in a van and driving you over to the dental clinic or the dental office, right? And then you have to go. And what if you're nonverbal and all you can do is act out? Well, maybe it's not the best day for you, right? So, realizing, and even if a person was verbal and then they had to get in an ambulette or an ambulance, and then they can't even go by themselves, they have to have another person. And that's a big barrier, right? And then, forget about the physical barriers once you actually get to the dental office and whether or not you can get maybe your bariatric wheelchair into the dental office, which is bigger than a regular wheelchair, or some of the other things, like we see patients who are on gurneys. Most dental offices aren't set up for that. So you might see those kind of actual physical barriers when accessing dental care. And we do know from the literature, and there's tons of it out there worldwide and in the United States, that access to care can be improved with formal and continuing education of our dental providers. So many studies on the formal, some studies on continuing education. So I applaud all of you for joining the special care army and wanting to move forward and work with our folks with special needs. So we always use people first language. If you get nothing else from this seminar, this webinar today, please use people first language. Okay, we always say people with, all right? It's a person with a disability. It's a person with epilepsy. It's a person who uses a wheelchair. It's a person who has a disability, right? We don't define someone by their disability, much like you wouldn't want to be defined by the one thing that you're, everybody has their thing that they're the person with the glasses or the bald guy, or, everybody has a thing that they are a little sensitive about. You don't want to be identified as that person. You want to be identified, as a person first. You'll see here that we have the R word highlighted in red. You should never, ever, ever use the R word. And you should feel very empowered to stop other people from using the R word. It is not acceptable. You heard it in some old things. It is not allowed during President Obama's administration. It was removed from every single federal document, okay? And so it is no longer a term to be used. We use intellectual disability. So I want to make sure that you remember that, okay? And I am constantly correcting my students who will come up and say, so I have this autistic patient. I say, do you mean you have a patient with autism? And it's a nicer way to say it. And they say, oh, yes, that's what I mean. And I'm constantly correcting other people around me. And I feel very empowered to do so. And you should too. And we're gonna watch a little video about that.
My guest tonight is the chairman and the CEO of the Special Olympics. And I hope he's ready to time me on my 10-yard dash. Please welcome Tim Shriver. Hey, Tim, thanks for coming on. Good to see you. All right.
having me.
First of all, I am morally offended to have a guest with better hair than I do.
Well, we could have a hair off, but I think you have so much goop in yours. That's why it's so high. I don't know why do you like it. What do you call product?
It's protective shield.
Gel.
I'm under these lights all day. Now, you're the chairman and CEO of the Special Olympics, and you are here to talk about wanting to get rid of, have people stop using the R word.
The R word.
Okay, what is the R word for people's education?
The R word is the old language we used to use to describe people who have intellectual differences. We used to call them mentally retarded, retards, retarded people. Language that's old.
I would prefer you not use that
Use
term.
that word.
Yes.
Thank you. Well, the show's over. I converted you.
Thank you so much.
It's nice to be on.
So there we see Tim Shriver, and here's my unabashed claim to fame. Here's my picture with me and Tim Shriver and the founding dean of ASDO, Dr. Jack Dillenberg, after the worldwide, this is at the Worldwide Special Olympics. And yes, that is Eunice Shriver's son. So the Kennedys continue to do good work with the Special Olympics, and Timothy Shriver runs Special Olympics, and he is a wonderful advocate for people with intellectual and developmental disabilities. And if you ever have the opportunity to hear him speak, you should go. He's an amazing and inspirational guy, and just absolutely wonderful to hear. And if you haven't spent a lot of time with people with special needs or with any kinds of people with intellectual and developmental disabilities, a good place to start is Special Olympics, special athletes, healthy smiles, special athletes, special smiles rather. A great way to volunteer and get involved in your community and see your patients or your future patients in a different light and watch them do all sorts of amazing things. This day, I remember I actually went to see powerlifting. So it's the international, right? Special Olympics. And I saw a guy with Down syndrome who was like 5'2", and he could lift over 300 pounds in the powerlifting. It was amazing. Like, they're amazing, amazing athletes. It was like going to the Olympics. It was super amazing and special. So I encourage you to, maybe if you haven't spent a lot of time, volunteering at Special Olympics is a great way to get involved with your developmental disabilities community in your community. Just some resources, and here is our plug for the next part of the webinar, which we're going to talk about developmental disabilities, and we're going to actually talk about treating patients with developmental disabilities now that we sort of set the stage and we talked a little bit about the history, and we kind of cleared up why we're not all up on our disabilities game and why we maybe need to be, and create some relevance. And that's where we're going next. So I think, Adam, you're there and we're ready for questions.
Absolutely. Thank you very much for presenting on this all important topic. Just to piggyback off what you said, our next session is on December 15th, 6 p.m. Eastern. If you haven't already and are interested in attending, please go to the link shown on screen and register for not only part 2, but for all or any of the future webinars devoted to treating patients with varying disabilities. All right, that said, let's get to the questions. We've got about 10 minutes left, so if anyone has questions, feel free to type them into the Q&A or chat and we'll get to them. The first question is, can you address what is known about dental schools meeting the accreditation requirements for teaching dental students to treat patients with special healthcare needs?
So all dental schools have to meet that, the standard. So the previous standard prior to 2019 was just that they had to assess people with special needs, which means that you could literally show a video and everyone could sit in a classroom. So you didn't actually even have to have a patient. Currently, you have to manage someone with special needs, which means you have to have clinic patients that meet the coded definition of a person with special needs. So it might be geriatrics, and a lot of schools use that. They might have a nursing home rotation or something like that. They use geriatrics as their, kind of their be all and end all. I think that the CODA that as more and more schools are developing bigger programs, the CODA site visitors are looking for a little bit more robust program. They're looking for people to actually, for schools to be teaching, clinically teaching people to work with people with special needs. And that means a variety of things, not just vulnerable elderly, but intellectual and developmental disabilities, patients with behavioral health issues, kind of the gamut. So they are looking for that, and people will have to at least meet those people in the clinic and at least, be doing, intakes on folks with disabilities. My fervent wish is that that we get to the point where we say that all dental students in America they must be competent to treat people with special needs. And I've promised everyone I will not retire until that happens. So CODA might do it just so I retire, I don't know. But I really want people to treat them, because we all know as dentists and hygienists, we have to do it. We physically have to touch the patient. We have to have that patient experience. And once we have that patient experience, then we're willing to continue to do it. But without patient experience, I mean, you're not just going to start doing something you never did before. That's not who dentists are.
During COVID, I felt that these communities are a bit isolated. Do you have any suggestions for maintaining that connection?
Yeah, so, we've had a very robust teledentistry during COVID, and we had it before, and we're very blessed that we have Dr. Scott Howell, who's been a pioneer in really moving teledentistry forward. So we've had a lot of caregivers with our patients get on teledentistry with us, and it's been really super fun, and our patients have enjoyed it. So that's one of the ways we've been keeping connected with our patients. And of course, we're up and running, so we're seeing patients. But teledentistry is a good way to keep that connection.
I am a registered dental hygienist and have a daughter with Asperger's syndrome. The invisible disabilities are often overlooked. Any suggestions for dental professionals to add an area on health history forms to be able to disclose their disability?
Yeah, so I think that it's important to either have an other, or do you have any other special, I like to say, do you have any other advanced care need that we should know about? Anything. And I think by asking that, is there any other need that you have that we could meet that you haven't told us about? And I've had people put in things like, I'm super sensitive to sound and I don't want to have music in the room, or I am really I don't want to be seen by male providers. I've had all sorts of things, up until people saying things like, I have Asperger's as an adult, and not putting that anywhere else. So if people aren't putting that in, if they don't have a neurodevelopmental question, sometimes people will put that in the neuro section. I like to ask it as more of a behavioral thing, like, is there something we can do to make you more comfortable? Is there something that you haven't shared that would make your visit better? And you could probably think about a good way to phrase that.
Great. Well, thank you for answering those. That's all the questions I have so far, but I do have a couple comments of praise in the Q&A. One from Pamela, who says she is honored to treat special care dentistry patients in her 31 plus year career in dentistry. And she encourages,
yay for Pamela.
She encourages everyone to embrace the similar calling to help address the disparities. And then a comment from John to thank you for your time, Dr. Perry. And as a pediatric dentist and orthodontist, he agrees that all dentists should have a working knowledge of how to treat people with special needs.
Yeah, and we're going to talk about it in the next one. About 85% of people with intellectual and developmental disabilities are at a 6th grade level or above. And I think pretty much all practicing dentists can work with a 6th grader. You kind of just have to speak to people at the right level. We always speak to our patients, and we're going to talk about that next time. And I think it's really important that the general dentists, take responsibility for learning to treat this population. And certainly the pediatric dentists and the hygienists are huge allies. And we love those communities. They help us, but the pediatric dentists aren't too keen on doing root canals or posting cores or crowns, and so general dentists have to step up. And that's a reason to, to take more CE, and that's a reason to spread that. So I'm happy that so many people joined us tonight.
Great. Well, thank you for your time this evening. And as a reminder, if you did elect to receive CE credit for today's webinar, it is required that you complete the survey upon exiting. I would like to thank you, Dr. Perry, for sharing your time with us today and presenting, and of course, thank everyone for attending. If you have any questions regarding CE or anything covered in this webinar series, please email us at webinars@henryschein.com and we'll get back to you as quickly as possible. I hope everyone will consider joining us for the remainder of this webinar series. Until next time, everyone stay safe and have a great evening. Thank you.